I think that was a masterful shortening, nevertheless. Questions for? You want to come up so you can, people can see you answer? I have at least one question before anyone gets up there, which is, you have a sense of the targeting one can do in the initial development of the program towards universal coverage, targeting one can do that makes it more likely that the inverse equity will turn out to be false in that case?
Yeah. Well, first of all, I hesitate to answer that question just because I tend to move toward thinking we really ought to focus on the differences and the specifics of the situation. But you ask, the one thing that does seem to be rather interesting is the record of outreach programs, mass immunization programs. And in that slide from Cesar that I showed, it's 25 out of 25 programs, 24 had increased equity. And they attribute that to or suggest at least, or speculate, that this was because that immunization programs have increasingly adopted aggressive outreach programs, mass campaigns, which may have efficiency concerns, but one, from an equity perspective, from reaching the poor, that may be the sensible way to go, and it makes intuitive sense. So I would have thought, get out there and take services to where the poor are. Close to client, I think, was what the WHO called it at one point. That's just the one very general thing I'd suggest looking at first, without a guarantee that it's going to work everywhere.
And can that be applied to a broader range of services beyond vaccine programs?
Well, yeah, I think bed nets, for example. There's no reason why don't start. There's a tendency, and Cesar has written about this too, to start projects in easy-to-reach areas because you want to establish a good track record of overall efficiency and then let it slowly spread out. I'd say reverse that process if you can get the political support for it. Yeah. As would it be a general applicability to almost any service one would have.
Norm?
Yeah. Thank you, Dave. And I was happened to be here for the longer presentation, but I will ask a more general question. I don't understand why there's a potential conflict with targeted procedures in a universal coverage system, because my understanding of universal coverage would be that you're trying to make sure that there is a certain kind of protection for the whole population. And if it turns out that part of the population can't be reached except through targeted procedures, then you would include them. Even in the name of equal protection. So I'm wondering if you want to say something.
No, I agree totally. And I think you just said eloquently, more clearly and articulately than I did, the basic point I was trying to make. But that was not it was opposing what was really a very common view, was that the two were opposed, and I was trying to make the point they're not.
Nir?
Earlier in your previous session of this, Alex Vorhov asked a question about the lifetime impact, and I want to ask another question about the lifetime impact. So imagine that an intervention to reduce chronic pain that the poor get 2 years after the rich, and the question is whether to introduce it at all in terms of equality or not to introduce it at all in terms of equality. There is a case to be made that equality supports introducing it despite this inequality, so not just efficiency, also equality. And the case goes, think about the entire lifetimes. So suppose overall the rich get, just throw out a number, 30 QALYs, and the poor get, because of that gap year, initially 29 QALYs. That's almost the same in terms of proportion, and so it dilutes any differences in quality distribution that exist in the background. So it improves equality.
Yeah, no, I'd agree. What more can I say? I don't.
In that case, maybe I thought that the thrust of the talk is that there is some sort of trade-off to be made in cases where the initial introduction helps only the rich in those years between equality and efficiency, or equality and the long-term interest of the poor. I see this as potentially a case where even equality sides with introducing.
Well, look, let's discuss it later, because obviously I'm just not following. I'm sorry, that's that's the problem's with me, not with you.
The tall fellow.
Yeah, the tall guy. I was, as you were talking, I was juxtaposing your remarks against Bill Schau's yesterday, and I thought, well, here are two really different approaches. So Bill says that he talks to the finance minister, and the cards he plays mostly have to do with the efficiency overall of allocating more money for health, because you get better economic performance and return on investment and so on. Now, suppose that it turns out, let's just accept what he said for a moment, and others have said, talk the same way. Now, suppose it turns out that keeping the kind of eye on equity, especially among the groups, the subgroups among the poor, as you've done so eloquently over years, suppose that is antithetical to that goal, because suppose that's just it's completely antithetical to the sort of thing, his approach, which is you're targeting the people who sort of matter least economically and cost the most. Now, I won't state this, I'll put it as a question. Is it possible that following your approach would remove one of the most important cards from his deck, which would mean that the amount of money that he could expect to wrest from the finance ministry in a given country would be low enough so that even the poorest groups that you're concerned with would actually wind up with less?
Right.
And what do we do about that?
No, that's an issue. I think there's a pretty good example of that was in Sri Lanka with food subsidies for the poor, where because they were only for the poor, they decreased government support from them, and even the poor ended up better off. I could see that as a distinct issue. And where that is, and Dean made a comment, I don't know if he's still here after my earlier presentation, that shouldn't you be worrying more about the absolute levels of the poor and not worry about inequalities and really focus on that mixture of services that increase the absolute inequalities. And if you have to increase the poor, the better off, even more. In order to do that, that's a trade-off you ought to accept. And I take that as essentially what the question that you're asking. And yeah, I think a case can be made for that.
Yes?
This is actually probably more a comment on your question, Norm, but it's, which I think really points us in the direction that we need to be going, because I think David's work points in the direction of something that is absolutely critical, because we continuously find, in the name of universality, equity sort of disappearing from the scene. But on the other hand, I mean, the problem, at least from our experience in India, my experience, I should say, is this, that people somehow assume that if you're saying universal, it is going to be equitable.
Right.
And because of that, equity as an issue to be grappled with just drops off the table. And people then move on to thinking larger system questions, whatever those system questions might be. How many doctors have we got per, square kilometer, those kinds of issues, and really don't address the question of groups that are likely to be left out in the process. So I think that, but what I think this may point to, even in terms of how you present your work, is maybe we need to step beyond the thing of posing it as a universality versus targeting question, because then that still sets it up in that way, and then you have all of the people who are for universality sort of bristling and calling you a World Bank targeter as an insult, intended insult. Continuously. And I think we need to get to the point where we're saying, look, if you want to do it this way so that you can actually get both things.
Yeah, no, that's fair enough. I think there are probably more graceful ways to put it than I did. I favored, in this particular case, clarity over grace, and I'm not sure that's the right way to go about it.
Any other questions? Okay, thank you very much.